We're good. Good morning. Dr. Shaikh graduated from medical school and general pediatrics residency in Philadelphia. He completed a general academic pediatrics fellowship at Children's Hospital of Pittsburgh and joined the faculty at the University of Pittsburgh. He's currently a tenured professor of pediatrics and heads the general academic pediatrics translational science unit. In the area of acute sinusitis, Dr. Shaikh developed and validated a symptom scale for use as an outcome measure in clinical trials, and collaborated to develop a method for processing nasopharyngeal swabs to allow for multiple testing. Dr. Shaikh recently published a large randomized clinical trial in JAMA, sponsored by NIAID, evaluating the efficacy of antibiotic treatment for children with acute sinusitis. In the area of acute otitis media, he contributed in a series of studies, all published in the New England Journal of Medicine, sponsored by NIAID and NIDCD, evaluating the efficacy, adequate duration of antimicrobial therapy in children with acute otitis media, and the efficacy of tympanostomy tubes in children with recurrent acute otitis media. In a series of 5 studies, he developed a symptom scale, the Acute Otitis Media Severity of Symptom Scale, used as an outcome measure in acute otitis media clinical trials, currently being certified by the Food and Drug Administration. He also authored 2 videos in clinical medicine in the New England Journal of Medicine on the diagnosis of acute otitis media and at performing diagnostic tympanocentesis. In the area of urinary tract infections, Dr. Shaikh evaluated prevalence, definition, diagnosis, and treatment in children. He developed a widely used calculator that identifies children at risk for UTI. He published the largest clinical trial to date evaluating the efficacy of corticosteroids for the prevention of renal scarring in children. He was a key contributor in the NIDDK-sponsored study evaluating the efficacy of antimicrobial prophylaxis in children with vesicoureteral reflux. He recently published a 9-year study sponsored by NIAID evaluating the duration of therapy for children with UTI in JAMA Pediatrics. The quality and influence of Dr. Shaikh's research is evident from the journals in which they are published, including New England Journal of Medicine, JAMA, JAMA Pediatrics, and Pediatrics, and the numerous NIH R01s he has been awarded in each of these areas. He has served in NIH study sections and American Academy of Pediatrics guideline committees. I have worked with Nader for, we just figured it out, 24 years. He's the most caring and thoughtful clinician who is inquisitive and methodical about every research question he asks, which invariably change the standard of care we provide to generations of children. We're on for a real treat. Buckle up. Nader.
Thank you for that kind introduction. So today we're going to talk about, we're going to talk about a bunch of stuff, like it's sort of like a potpourri of various topics. So we're going to start with sinusitis, randomized controlled trial on the treatment of sinusitis. We're going to then move to UTIs, talk about a tool for deciding when to test children for UTIs, screening tests for UTIs, the definition of UTI, duration of treatment for UTI, and then we're going to switch to AOM. We're going to talk about AI for the diagnosis of AOM and bacteriology of AOM. So to start with sinusitis, we recently completed a large trial, and I wanted to go over the rationale for this trial. So acute sinusitis is the 5th most common reason for antibiotic prescription in the US, which is a lot of antibiotics. It's 5 million antibiotics a year. There's 2 main presentations of acute sinusitis: persistent, which means you have a cold that doesn't go away and it lasts more than 10 days, or worsening, which is a cold that gets better and then it gets worse on day 6, 7, 8, 9, or 10. And that's presumed to be bacterial sinusitis. So these are the definitions. They're clinical definitions. They're not very backed up by evidence, but it was thought that these definitions would at least reduce antibiotics, prevent us from giving antibiotics to every child with a cold. But we had preliminary data suggesting that only a subset of these children with this definition had bacterial disease. So we were sort of trying to reduce antibiotics further from this starting point. And that's why we designed this trial. The question we asked in this trial was whether we could We wanted to assess if antibiotic therapy could be appropriately withheld in pre-specified subgroups of this, meeting these criteria. And specifically, we asked whether the efficacy of antibiotic treatment differed based on nasopharyngeal colonization with a bacterial pathogen and the color of nasal discharge. This will become a little more clear when I go over the results, but the methods were, this was a randomized placebo-controlled double-blind trial. We enrolled 510 children. The two arms were amoxiclav and placebo. The primary outcome was the symptom scores over the first 10 days. We treat sinusitis to improve kids' symptoms, so we sort of needed a symptom score to ensure that we were measuring the right outcome. And we measured this every day, so this provided us with more granular data than was done in the previous studies. We enrolled kids 2 to 11 years of age at 6 institutions. The study took 6 years. Every child had a nasopharyngeal swab at the time of diagnosis, and we send that to the micro lab for culture for H. flu, strep pneumo, and varicella, which are the pathogens thought to cause sinusitis. And in preparation for this trial, we started developing this scale in 2011. This is the scale we used as an outcome measure. So we had to develop and validate the scale. We ended up with these 8 symptoms, all measured on a scale of 0 to 5. And they're the typical symptoms of sinusitis that everybody knows about: stuffy nose, congestion, cough, trouble sleeping, not having trouble breathing. So this was our outcome measure administered every day. And these are the results. They're a little bit complicated, so I'm going to focus on the part that's important. This is the most important finding from this study is in this graph, which shows on the y-axis, you can see the symptom scores. So that's, you can see the symptom scores on the left, and then on the x-axis is the time. So everybody gets better over time. So the symptoms start high and they go down. And the main finding of the study was that in children with no pathogens in their nose at baseline, the two curves are pretty much the same. So it didn't matter if the children got antibiotics or placebo, they did the same. So our conclusion was, if you don't have pathogens in your nose, you probably don't have pathogens in your sinuses. Therefore, you don't benefit from antibiotics. And this is shown by this curve. In contrast, the children who, to the left of that curve there, in panel B on the left, you can see there's a difference between the two curves. So that's how much benefit you can expect from using antibiotics for a child with sinusitis. Again, both curves go down. It's not like placebo. If the children who got placebo did terribly, they did okay, they got better, but at a slower rate than children that got antibiotics. And the two curves are separated. And the p-value there, you can see 0.02, that's the difference between the two curves. So the interaction was positive. So there's a difference between children with pathogens in their nose and the children who don't have pathogens in their nose. So the amount of benefit from antibiotics was also sort of clarified in this trial. The difference between the two curves is 2 points, pretty much from day 2 to 11. You can see the curves are separated by 2 points, and that's basically 2 points on that scale that I showed you. So if you treat, you can expect that much difference, which is basically a difference between an extreme amount of fussiness, let's say, to some fussiness. So you'll have a child who's extremely fussy for 10 days versus somewhat fussy for 10 days. That's how much difference you can expect. So the data can be seen in 2 ways, really. Placebo sort of wasn't too bad, really. So this can support the use of careful observation for acute sinusitis. But on the other hand, these parents have been dealing with this already for a while. So this is not like the child has been coughing for 10 days or so. And so they might want something done. So antibiotics do work. This is what this study also shows, that it works, but it also shows you the magnitude of the benefit. And the next finding is on the bottom panel, panel C, which shows the 2 curves for nasal discharge being colored and clear. And you can see the 2 curves are separated in both panels, which means that colored being, even the kids with clear nasal discharge benefited from therapy. So asking parents about the color of the nasal discharge is not useful. It doesn't help you decide whether antibiotics are work or not, and we shouldn't be asking that, really, because it causes confusion in the parents, and that's sort of drives up antibiotic use. Okay, so the conclusions of this study was antibiotics really don't work for children who don't have nasopharyngeal pathogens on presentation. And testing for bacteria at the time of presentation can reduce antibiotics. So if we imagine a situation where we know if the child has pathogens or not in the nose, we can reduce antibiotics by 50%. And that's what we did in this trial. We tested everybody at presentation. It's not that difficult, and these are not difficult things to test for. H. flu and strep pneumo are the two main pathogens. They're commercially available tests for them. There's PCR for both bacteria and even a rapid antigen test exists for strep pneumo. So these are not these are not pathogens that are difficult to test. We just don't have it on our panels in our clinic. For example, in our clinic, we have a machine that can test for COVID and flu, but we don't have something that can test for these two bacteria. And these things have to be developed and put on ordering panels, but it's not something that's really difficult to do. So I'm hopeful that in the future, testing treatment of sinusitis might become like the treatment of streptococcus pharyngitis. So we do a swab, we test them in the clinic, and then we tell the parent that this child might benefit from antibiotics. And that way we can limit antibiotic use to 50% of what it is now, which is 2.5 million less prescriptions a year. Another aspect of this study was how we process the swabs. Dr. Williams in infectious disease actually helped us develop this protocol, which was sort of unique at the time, where we sort of used one nasopharyngeal swab, but we did these 3 tests from it. And we sent, as we discussed, we send the swabs for culture to the micro lab downstairs. We also did PCR for viruses. And we also send the swab for metatranscriptomics. So we looked at the total RNA on the swab. And the RNA can be from the host. So the host is doing stuff in response to the bacteria and viruses in the nose, and we can see what it's doing. And the bacteria are doing stuff, so we can see the RNA that the bacteria are producing, and the viruses are there so they can be picked up with this method. So we sort of had a lot of data, which we are still working through. But the first thing we asked is, how do these, how does this compare? What information does metatranscriptomics provide us compared to what the clinical lab is telling us? So first we looked at the bacteria. This is a slightly complicated slide, but this slide is looking at the concordance between the RNA-seq or metatranscriptomics and culture. So on the left side on panel A, you can see that culture for the 3 pathogens is shown in gray and white. So let's take the MCAT, Moraxella catarrhalis. The first patient had a gray bar. That means they had Moraxella on culture. And the second patient had a white bar, which means they didn't have Moraxella. So the gray and white columns represent the culture results from the micro lab. And then the colorful bars represent the metatranscriptomics data. The more blue, the more transcripts they had. So the really blue patients had more Moraxella. So you can see in general that the culture results and the metatranscriptomic results are sort of concordant. And if you look at the panel C, the AUC for that relationship is 82%. So if you had the metatranscriptomics results, you could predict culture results with 82% accuracy, which is not too bad. The second one for strep pneumo, you can see the concordance is a little bit better, and the AUC is 89%. So you can predict culture results for strep pneumo for 89% accuracy, and H. flu was almost perfect. So if you have the metatranscriptomic results, you can see who has H. flu and who doesn't. Then we looked at viruses. Instead of the bacteria being on the top, now the viruses are in the top. So we had these from Dr. Williams' lab, influenza A, for example, on so influenza A, B, C, metapneumovirus, RSV, and so on. So again, we have the PCR results on the left. So you can see the first column is influenza A PCR, and the second column is influenza A metatranscriptomics. So you can see there's a close concordance between the results of the 2 tests. And overall, after 12 viruses that we had PCR results from, 9 out of 12 we detected with a sensitivity of 90 to 100%. And the three viruses did not work well. The influenza C, HRV, and adenovirus were not detected by metatranscriptomics as well. I'm guessing adenovirus is a DNA virus, so maybe that's why, but I'm not really too sure. But overall, the metatranscriptomics is giving concordant results to the clinical testing. And then finally, we looked at the host expression. So we wanted to see what is the host doing in response to these infections. So we divided the patients into 4 big categories. So you can see on the left hand column where it says low and low on the bottom. So those patients had neither bacteria nor viruses. So they didn't have anything in their nasopharynx that we could pick up on clinical testing. The second column, the children had a viral pathogen detected, but no bacteria. The third column had bacterial pathogens, but no viruses. And then the fourth column, the kids had both viruses and bacteria. So we developed 2 signatures. One was for viruses, one was for bacteria. So you can see the children who had no bacteria or viruses, both panels are pretty much blue on the left. The 2 panels on the left are blue. And there you go. I found the pointer finally. So these 2 panels are blue, which means that neither virus or the host is reacting to neither viruses or bacteria. And then in the children who had a viral pathogen, the second column here, you could see the viral signature is turning red. And in the children who had bacterial pathogen, the third column here, the bacterial signature is turning red. So, and in the children who had both, we have redness in both top and bottom, which means that the host is sort of responding to both bacteria and viruses. So this is sort of interesting that you could sort of tell what kind of infection is going on by looking at the host expression. So overall, so then the next thing we asked was whether it's sort of cumbersome to do total RNA sequencing and look at a signature with 200, 300, 500 genes. That's sort of not useful clinically, but we were asking whether maybe we could pick out of these 200 genes in each signature, maybe we can pick 1 or 2 that will tell us the same thing. So this is what we looked at in this figure here, which is called the volcano plot. On the y-axis is the p-value, so how significant it is. The higher up, the more significant. And on the x-axis is the fold change, or the magnitude of the association. So you can see that the markers here, for example, CXCL11 and CXCL10 are very, very high. Those are very good markers of viral disease, and this has been shown by others. So those alone could just tell you, if we have a test with that, a strip with that on it, we could probably declare pretty well who has viral infection. And the same thing we're trying to do for bacteria, except it's a little bit more jumbled in there, and we're still trying to find good markers that will tell us about bacterial disease. Okay, so overall, what did this metatranscriptomics data show us? We basically provides a overall picture of what's going on. It tells you what viruses are present, what bacteria are present, and what the host is doing, just using a small part of the swab, which is really amazing that you can get so much information just with one little piece of the swab. And this, I'm sure that with over time, this method is going to improve in accuracy. So I think it does have potential to be used either in clinically or to identify markers that can be used clinically in future studies. Okay, I'm going to switch over to UTIs now. I wanted to remind everybody about the 2011 guidelines. In those guidelines, the 3 big topics were dealt with: who to test, which children should be tested for UTI, the definition of UTI, and how long to treat. And we're going to go over what's changed since then. So first, who to test. The AAP guidelines recommended using these 5 criteria to decide who should be tested: race, age, maximum temperature, duration of fever, and absence of another source of fever. Well, what's changed now is we have this tool called UTI Calc. This is version 3. And what's different in this tool is that race is not one of the categories, and the tool has been validated several times. The way this thing works, on the left side here, you enter your patient's characteristics. So for example, in this patient, This patient was a theoretical patient, was a child less than 12 months of age who did not have a maximum temperature greater than 39. The child had a history of UTI, was a girl, did not have another fever source, and did not have duration of fever greater than 48. You put your child's characteristic in, you click on calculate, and it calculates a number for you. So the calculator is telling you the child has a 21% pretest probability of UTI, which you can then take to the parent and say, your child has a 1 in 5 chance of UTI. I would like to do a catheterization. And the parent will say, well, I don't like it too much, but go ahead because it seems like a large number. So you get your urine, and the child has no nitrates and 2+ leukocyte esterase, and you enter those in. The white cell count never comes back on time, so you don't need to put in all these things you don't have. And then you click on calculate, and it goes up from 21% to 71%. So your post-test probability of UTI is 71%. You go back in the room and tell the parent that the probability is high for UTI and you treat. So this is how this tool works. The differences with what we had before is that it gives you a number, a probability, which you can sort of use in your discussions with the parent instead of just telling you test, don't test. So it's a little bit more transparent. Race is not one of the predictors. We'll talk a little bit about that in a second. It's been externally validated in those references down below. At Lurie Children's and at Duke, and it's being validated in Canada. It's freely available online. If you Google UTI calc, it should be the first thing there. Race and UTIs is a really complicated topic. We don't really have too much time to go into it in depth, but you shouldn't be using race to determine who gets what tests, because that's sort of like the definition of racism. And we did include race in the version 1 of the calculator, and then we got sort of smarter and we decided to replace it with 2 other variables. So we took race out and we put these other 2 variables in, and we showed that the accuracy didn't decrease. But I was a little bothered by this, because I was wondering if we were making the tool look better or were we making it function better? Because empirically, there's a question whether taking race in out might have made things look better, but might have decreased the fairness of the tool. If race is related to UTIs, it theoretically could have done that. So I wanted to look and see if the fairness of the tool and how it performed improved, and not just how it looked. So we I had no idea how to measure fairness. So I collaborated with these colleagues at the School of Bioinformatics, and apparently fairness is a well-studied topic. So the measurement of it has been extensively researched, and there's at least 16 ways to measure fairness. So these folks took these 16 measures and looked at the version 1 of the calculator, which had race in it, and version 3, which didn't. And I'm just listing 3 examples on the bottom here, which I could understand at the 16, but basically you want the tool to be equally sensitive in both groups, African Americans and whites. You want it to be equally specific, and you want it to be equally accurate. It should sort of perform the same. So the difference should be 0 in sensitivity, specificity, and accuracy. So when we looked at version 1 versus version 3, you want to look for numbers that are close to 0. That would be better, or dark green. And you don't want anything red or orange or yellow, because that means the difference is higher. So in version 1, we hadn't looked at sensitivity and specificity. We sort of had focused on overall accuracy, and you could see that from version 1 to version 3, the fairness has improved, and we're close to no difference now. So changing the tool did make it more fair. So basically, what's new for UTI testing? UTI calc is available and looks like it works. The second issue was the diagnosis of pyuria. So in 2011, the AAP said pyuria should be required for the diagnosis of UTI, which was new in that guideline. It wasn't the case before then, and in other guidelines, it's not like that. And just to give you a little bit of history, in 2010, a large meta-analysis was published for screening tests for UTI. And in this study, 95 studies were included, which is probably one of the larger meta-analyses in pediatrics. These 95 studies examined the accuracy of screening tests for the diagnosis of UTI. And they concluded that the screening tests we have, the white cell count, the leukocyte esterase count, and the leukocyte esterase and the combination of leukocyte esterase or nitrites are okay. They're mediocre in sensitivity and specificity. They're not great, because the numbers, as you can see, are not close to 100%. So this was done in 2010, and curiously in 2011, suddenly the AAP started requiring pyuria, which was sort of always didn't make a lot of sense to me because the data says one thing, but the AAP is saying something else. So there's something going on that's funny. So why did the AAP require pyuria when we know that pyuria has low sensitivity and specificity? This is the rationale that the AAP gave for this move. So they said UTI is an infection and should be accompanied by inflammation, which sort of makes sense. So they said, therefore, if no pyuria, no UTI. So if you don't see pyuria, it's not a UTI because it should always have inflammation. And therefore, children with a positive culture and no pyuria must have either asymptomatic bacteriuria or contamination. So this is what the AAP imagined on the bottom, which is all those children with a positive culture. Most of them have a UTI. There's a small group that doesn't have a UTI. Those are the children in yellow. The yellow children have ABU, or say asymptomatic bacteriuria or contamination. So this sort of makes sense if you look at it at this level, but if you look at it carefully, it sort of falls apart. So the first question is, how large is that yellow thing, the subgroup without pyuria? So we just know from the slides I showed you, those 95 studies showed us that the sensitivity of the leukocyte esterase is 79%. And that's what we use to measure pyuria. So what does the sensitivity of 79% mean? That means that 21% of children with positive culture, by definition, this is not my opinion, this is just the definition of sensitivity, will not have pyuria. So 1 in 5 children with a positive culture will not have pyuria in the way the test is used in the community. Per the AAP, these children must have ABU or contamination. So can ABU and contamination explain such a large group, large subgroup? So the diagram has changed a little bit. As you can see on the bottom, there's a children with positive culture, but now 1/5 of them are yellow. So this is a large number. So asymptomatic bacteriuria, we talk about it a lot, but it's extremely rare. This has been studied extensively in well-designed large studies, and a pooled analysis of that showed that the prevalence of asymptomatic bacteriuria without pyuria in this age group is 2 in 1,000. So most of us will never see a child with asymptomatic bacteriuria under 2 who has symptoms. 2 in 1,000, if you do 1,000 samples, like that's a lot of samples to do in your career, and you probably won't see it, but we talk about it all the time. So there's sort of, again, that mismatch there. So ABU cannot explain why 1 in 5 symptomatic children has a positive culture with no pyuria. And contamination is also unlikely. Contamination occurs all the time with catheterized samples. We see it all the time, but usually there's multiple organisms present, or usually the counts are less than 10,000. So it's usually clear what samples are contamination, and we're not going to confuse it with a positive culture, especially on cath samples, because of those factors. So contamination also cannot explain 1 in 5 symptomatic children has it a positive culture and no bacteriuria. So the contamination is shown in red, the amount of contamination that can be expected. The ABU is shown in green, and there's a large yellow part that's left unexplained. So what do those yellow children have? So they likely have a UTI because that's the only thing they can have. There's the only 3 things that cause a positive culture, as far as I know: ABU, contamination, and true UTI. So if ABU and contamination are not that common in catheterized children with symptoms, then they probably have a UTI. So you might ask, why did they have a UTI and no pyuria? Well, we know from that study that pyuria is not always present when there's a UTI. It's just not a good test. So it's not surprising that the pyuria is not there. And that's the conclusion that 95 authors drew that when they did their individual studies. They concluded that the test was not so good, not that the urine culture was broken or that everybody had ABU or contamination. So the problems with the logic from the AAP is, the first argument they had is UTI should be accompanied by inflammation. So if no pyuria, no UTI. The problem with that is that it assumes that pyuria is a perfect marker for inflammation, which is categorically not. And then the second problem is children with a positive culture with no pyuria probably have ABU or contamination. And we see that there that also that can't be true because the numbers don't add up. Another thing, this is a final nail in the coffin, I think, is that we have other tests that are better than the leukocyte esterase, which shows that the leukocyte esterase cannot be perfect if there's other tests that are better. So this is a study that when we were locked up during COVID with our kids at home, so my child there and Dr. Raja Kumar's child and some Dr. Hoberman's friends' kids were free, so we put them to work, and this is what they came up with. So they looked at this test called NGAL, or neutrophil gelatinase associated lipocalin, in children with UTI, and you can see this test is performing much, much better. So these are the studies, the 4 studies that were available at the time, and this is the ROC curve. So the closer you are to the left, the more perfect this test is, and you can see in some of the studies, this test is performing almost perfectly. So, and you can compare it to the leukocyte esterase here, which is not perfect. It's around 70–80% accuracy. So this test is performing perfectly, and the leukocyte esterase isn't. So that shows you that maybe the AAP's logic wasn't wrong, but maybe they picked the wrong test. So all of our guidelines is based on a leukocyte esterase or the WBC count, which are not good tests, whereas there are good tests available, and we shouldn't be relying on the leukocyte esterase test given its poor performance. So based on the data, I think this is my opinion really based on those data, but I think we should use pyuria in practice because it's a helpful test like we saw in the first slide. It took our probability from 21% to 71% in that hypothetical example. So it's very useful. We should continue to use it. It's a quick and dirty test that's very helpful because it's available and it costs a few cents. But we shouldn't require for a diagnosis, because when we say it should be required, that means it's no longer a screening test. That's sort of, we're elevating this test, which is not so good, from a screening test to a gold standard level test, which cannot support because it's not that good. And we should send cultures on kids who were catheterized, because we went into the room and told the parent that we were really worried about their child. The probability of UTI was 20% and all that stuff. And we convinced the parent to give us a sample. Then we come out and dip the sample with a not so good test, and we decide that it's negative, and we throw the sample away, which is called reflex urine cultures, which is happening all over the place, and that's not a good idea given the characteristics of the test. And the third thing is, most of the children with bacteriuria without pyuria, like we saw, have a UTI just based on the numbers of children and the performance of the test. So I think we should be treating these children. I don't think we're going to be causing antibiotic overuse by appropriately treating children with UTI. The next thing that was on the guidelines is the use of a cutoff. They recommended using a cutoff of 50,000 CFUs per ml, colony forming units of bacteria per ml for catheterized samples. So cutoffs we use all the time in clinical medicine to decide who to test and treat. For example, a procalcitonin level of 1.71 has been suggested as a good cutoff for serious bacterial infection. How did they come up with that number, the 1.71? Well, they do that by comparing the test, the procalcitonin, with the gold standard, serious bacterial infection present or absent. And that type of study where they do compare the two things is called the diagnostic accuracy study. And in UTIs, we've never done a diagnostic accuracy study. We looked at the culture and we're like, well, the 10,000 cutoff looks good, and then the 50,000, maybe that's better, or 100,000. So we've sort of guessed at which cutoff would be better, but to really determine a cutoff, you have to have a diagnostic accuracy study. And the reason this study was not done before is we never had the ability to, we had the urine culture and that was the only test we had. We had no other test to compare it to. So we couldn't do a diagnostic accuracy study. But nowadays, technology has provided us with an answer for this. So we have the microbiome analysis that can be used as a gold standard. The way this works is you have your urine sample. I'm simplifying a lot here, but you have a urine sample, you put it into the sequencer, and then you see what sequences are, it will sequence all the DNA in the sample that belong to bacteria. And then it will tell you what sequences are in there. And then you go and map it to known bacteria. So in this hypothetical patient, 98% of all the DNA mapped to E. coli and 2% mapped to other things. So you can plot the relative abundance there and you can see almost everything is E. coli in this patient. So this is basically a symptomatic child who has overgrowth of E. coli, which is basically another word for UTI. So this test can be used as a gold standard for UTI. And we had done some work before we did this study to show that this test was actually a good gold standard. So in this study, we enrolled, so this is the diagnostic accuracy study I'm talking about. We enrolled febrile children less than 2 years of age presenting to our emergency room who had a urine sample collected via catheter to rule out UTI. So they all had symptoms. Urine was sent for a microbiome analysis. I'm going to call that MCA, which was accomplished using 16S rRNA amplicon sequencing. We also assessed markers of inflammation, pyuria and NGA. And we declared children who had a dominance of one bacteria, so bacterial overgrowth, as having a UTI, and we used the cutoff of 80% for that. And it turned out that the cutoff really didn't matter at the end, but it was sort of arbitrary, but no matter what cutoff we declared, all the children with UTI had just basically one organism. And that was very clear. So they were very different from the other children who had no UTI, who had a smattering of normal flora. So we used this to define UTI, and then we looked back at the culture to see what cutoff was best. And these are the results. We enrolled 334 children, and 46 had a UTI, 295 did not. A cutoff of 10,000 identified 45 out of those 46 children correctly, and 291 out of the 295 children with no UTI correctly. So it was almost a perfect concordance between the urine culture at 10,000 and microbiome analysis. A cutoff of 50,000, however, 9 out of the 46 children who had symptoms and inflammatory markers were missed. So the sensitivity dropped to 99 to 80%, from 98 to 80%. Of note, the specificity stayed the same. So by lowering the cutoff, we're not going to increase antibiotic use much. So in this study, in this 341 patient, 2 extra children would have gotten antibiotics. But 8 extra children would have been diagnosed with UTI. So it seems like a win-win situation. So this preliminary evidence supports the cutoff of 10,000. Other studies have to be done because this was sort of a novel use of microbiome analysis, so other studies are needed. But one important fact also came from this Swedish study that I cited down here, the Swerkerson study, which showed that children with low counts are not just having mild UTIs and can be ignored. They showed that a good number of these children with counts of 40, 30,000 had pyelonephritis on DMSA scan. So just because the counts are low doesn't mean they don't have pyelo. So we sort of need to pay attention to this group. So I think the new data sort of leans us towards the 10,000 for catheterized samples. The last thing on the UTI guideline was duration of treatment. They said treat for 7 to 14 days. And 2 new studies have been published since then. The first one is a SCOUT study. This was a randomized controlled trial, double-blinded study, which had 664 children. And this it included 635 females and 25 males. It was conducted at Children's Hospital Pittsburgh and Children's Hospital Philadelphia. The children were randomized 1-to-1 to standard course, which was 10 days, or short course, which was 5 days of antibiotics followed by 5 days of placebo. Everybody was blinded. The primary outcome was UTIs at the end of treatment. So early recurrent UTI was the outcome. So the findings are shown on the right. 0.6% of the standard course patients and 4.2% of the short course patients developed the UTI soon after the end of therapy. So there's 2 ways of looking at this data. One, you could look at, say 0.6 is less than 4.2, so it wins. So standard course is better, so which is true. Standard course was statistically better than short course. The other way to look at it is to say, well, those 2 numbers are both very, very low. We sort of had guessed much higher numbers when we did our sample size analysis, and many people would be happy with a success rate of 96% in short course. So that's how we sort of looked at it. For most children, having a 96% success rate is good enough, and 5 days is probably good enough for most children. I'm going to talk a little bit about the second trial, which was published like a few days ago. And this study was done in Italy, was similar to the SCOUT study, but all included children were febrile, whereas in the SCOUT study, 38% were febrile, which means 250 patients in SCOUT were febrile. This study had 142 patients, and it was unblinded. At the end of therapy, 4 out of the 70 children, which was 5.7% in the standard course, and 1 in 72 children 1.4% in short course had a recurrence. So again, you can see the numbers are low. Both groups did pretty good, which is similar to Scout, but the results were flipped from Scout. The short course did better in this study, and the standard course did better in Scout. So that's a little bit odd. So my conclusion is that we didn't have enough febrile children in either study to make a definitive statement. You really need 500, 600 children to be able to see what's going on. So given that the numbers of febrile children we had were low and the two studies are showing opposite results, I think we should probably wait and treat children with pyelo with 10 days, and children who don't have pyelo can probably get 5 days. So the conclusion of this part was treat for 5 days unless they're febrile at presentation. One other question we were trying to deal with UTIs is we didn't understand why some kids get pyelo when some kids get cystitis. Why do some kids end up with pyelo? So we were thinking maybe the E. coli is aggressive and in some kids and it goes up and just gives you pyelo. So we collaborated with the Broad Institute. We sent them 57 samples of children with UTI, E. coli only, and 18 of those kids had pyelonephritis, 39 had cystitis, which was proven by DMSA scan. Again, on the right, you can see these graphs that are becoming sort of familiar. You can see the ID numbers of the patients over here. And then on the pink, dark pink is pyelo. So the second patient had pyelo, the third patient had cystitis. If you look at the pyelo patient, all of these, we were hoping to find something really dramatic that would tell us why the E. coli's go up to the kidney, but this is the only finding that we found, which was sort of disappointing. But the finding was that the kids with pyelo, like for example, this second child in dark pink, has all of these genes in the PAP operon present. So this whole bar of gray is there for the kids who have pyelo. And what does this PAP operon do? It encodes for P. fimbriae, which is those hairy things that stick out of E. coli, which help it stick to the urothelium. So maybe if you have all of these PAP genes, then you are more sticky, and maybe that will help you ascend, and maybe that's why you get more pyelo. So this is what we found. But as you can see from the picture here, this is not, it was significant, but not clinically useful. For example, if you look down here, these children have cystitis and they have the whole PAP operon. So we can use this clinically, although it tells us one reason that E. coli can ascend, but clinically it's not that useful. And this sort of, I think our question was a little bit simplistic to start with, because we were expecting to find something just about the E. coli that would explain everything, but it's probably has something to do with the host and the interaction with E. coli, and it's complicated. And in a previous study, we also showed that timing does matter. So how long the E. coli has to ascend is another factor. So we probably have to do some other larger study, which is looking at the host bacterial interaction and timing and all that stuff. So in conclusion, I'm going to wrap the UTI part up. So we sort of learned that there's a tool called UTI Calc that's available to use that seems to work. I don't think pyuria should be required for the diagnosis. Just using it is okay. If a child was catheterized, I think we should send urine cultures. The cutoff of 10,000 seems to be supported by some preliminary data, and treatment for 5 days seems appropriate unless you have fever to start with. Just a little bit about AOM, which is not a long section. But over the last 5 years or so, we've been developing this tool for the AI tool for the diagnosis of AOM. Dr. Hoberman is the main driver on this project. And you can see him on the left side using the tool on a child. And the way this thing works is we have an iPhone connected to a regular otoscope, and there's a coupler, so everything is there's nothing complicated with the hardware. We've just installed this app that you can see on the phone there, and we put this device in the ear and we push this red button, which is record, and this is the app, and it records the picture of the ear. On the right ear, and then we move on to the left ear and we do the same thing, and then we click on submit down here, and this goes to the cloud, and we have this AI tool built, and we'll come back and tell you, like for example, for this picture, AOM 99% confident on the right, and then the left side it will tell you it's normal. So this thing is how this works. The way we developed it was it was a 5-year study. We had children in our clinic with suspected AOM. We took videos of their TMs. We took 1,151 videos. Then an expert panel assigned diagnosis for each video, AOM or no AOM. And then that diagnosis was used to train a model. And the model was tested, and it works well. It has a sensitivity and specificity of 94%, which is better than most of us. And this could be used by a triage nurse. So the tool seems to work even on the testing cohort. And so therefore, I think it's ready for use, and it's being used in several CCP offices. How to use it is still a mystery. Like, we could give it to a triage nurse who's taking the vital signs. They can put it in the ear and take a picture and have a diagnosis ready when the doctor goes in. That could be done. So AOM diagnosed as a vital sign. The main limitation is cerumen, which is always a headache, especially in little children. So we need more studies to understand if how to use this in the clinic and what the implications are. How often is cerumen a problem? How often does what does it do to antibiotic use? Does it make it go down or up, or increase more appropriate antibiotic use? So those have to be studied. But the tool is the accuracy of the tool has been established, and it can be used. We did a small study on the bacteriology of AOM, looking specifically at Moraxella. The way we did this, we reanalyzed data from 2 previous randomized controlled trials in which both nasopharyngeal samples were available and middle ear fluid samples. So these children were had either a tympanocentesis or a perforated tympanic membrane, and we got samples. So we had both ear samples and nose samples, and we were looking at the concordance of the two. So as you can see in the first column here, out of the 164 children we had, 97 of them had Moraxella in their nose, but only 11 had it in their ear. So many children have Moraxella. They're colonized with Moraxella, but it doesn't seem to make it to the ear so often. Whereas strep pneumo and H flu, they were also frequently found in the nose, but more frequently found in the ear. So our conclusion from this was Moraxella is often in the nose, but it doesn't seem to be able to compete in the ear. So only 2 children in the whole in this 164 had Moraxella alone in their ear, in the middle ear. So it seems to be either it doesn't make it to the ear, or once it's in the ear, it gets outcompeted by H flu and strep pneumo. And this is something that needs to be figured out, why it's a little bit different than the other 2 pathogens that seem to be more autogenic. Finally, we sort of we're wondering if we can have to continue to do cultures and wait for the results of the cultures. So the way we do things now is, for example, we do a tympanocentesis, we get pus out of the ear, we send it to microbiology. 3 days later, if we send it to children's, or like a week later, if we send it to Quest, they will tell us what's in there and if it's resistant or not. So waiting for cultures is sort of not very exciting thing, because it takes a long time and the patient is waiting. So we always have to guess what antibiotics to use. So we, in this study, we were wondering whether we could use the information from the genotyping the organism to tell us whether the organism is resistant or not. So this is part of an ongoing study of strep pneumo serotypes that we're doing. So we took the first 101 patients in this study. And those children had 71 instances of strep pneumo. So we send the strep pneumo for whole genome sequencing. So we genotyped the strep pneumos, and we wanted to see if that would tell us whether the strep pneumos were resistant or not. So again, I'm going to walk you through this. On the right here are the ID numbers of the patients, and these are the serotypes we found. You could see the serotypes that are prevalent now are 35B, and a new serotype that's very aggressive and emerging is serotype 3. So this is telling us the serotypes that are common in children with otitis media in this era of vaccination, and this is changing now with the new vaccine. So that's what the study is about. And then on the last column here, we can see what the micro lab said. So in the first patients, in the first 5-6 patients here, the micro lab said these children are resistant. They had strep pneumos that were resistant to penicillin. And in the middle part, you could see what the prediction was from the genotyping. So you could see in the first 5, 6 kids that had predicted to be, that had a resistant strep pneumo, the prediction matched. And in the next bunch of kids who didn't have it, they also were not predicted to be resistant. So again, here we see a sort of a novel use of genotyping to predict who has resistant strep pneumo or not. So the match was not perfect, because just because you have the genes for resistant doesn't mean you're going to exhibit them clinically, but it was pretty good. So for a first try, it seems pretty accurate to do. So with that, I wanted to leave some time for questions, because this was a whole mishmash of things. I wanted to thank the clinical team that makes all the studies possible. This is a little bit older picture. I couldn't find the new one. And then I really wanted to thank the two the senior scientists I have in the lab, Jayza and Sojin, for the work they do.
Thank you.